I now have the distinct pleasure to introduce Dr. Joanna Katzman. She's the director at University of New Mexico Pain Center and medical director of ECHO Institute Pain, Substance Use, and Public Health Programs. And it's fantastic to have her with us today. We're very grateful for her time. And now I will turn it over to you.
Thank you, Amy, and thank you, Maggie, and thank you for the leadership to allow me to come talk today. I am Joanna Katzman. I'm a neurologist, and I work both at the University of New Mexico to direct the pain center there, and I serve as the medical director over the pain and substance use and public health programs at Project ECHO. So I am so glad that Maggie spoke a little bit about telehealth and telemedicine. And I would like to briefly share my role as overseeing the ECHO pain programs at the ECHO Institute. You can now start my slides, Amy, that would be great. So just I want to briefly state what you already know, in that at least 50 million people in the US suffer from chronic pain. In 2018, we had almost 165 million people over the age of 12 who were using substances at least once a month. 2 million people in the US in 2018 were diagnosed with an opiate use disorder, and 10 million were this was from the National Survey on Drug Use and Health, were diagnosed as having an opiate misuse. In 2018, we also know that we had a staggering uptick in the number of recorded suicides, almost 50,000 suicides, a significant rise from 4 years prior. And then a huge epidemic, not only in the US, but globally, with loneliness, approximately 42 million people, or almost 14% of the US population. So we need to do something better when it comes to chronic pain. I'm going to very briefly tell you about Project ECHO. I got involved in Project ECHO in 2008 and started the ECHO pain program here at the University of New Mexico. And now we have about 120 ECHO pain programs in the United States and globally. ECHO is a telementoring forum whereby clinicians teach other clinicians in rural and urban underserved communities in the United States and globally. We now have all 50 states involved and over 40 countries. ECHO moves knowledge, not people. And there's never a patient on the other line, so it's clearly an educational forum. It's really a distance, virtual, curbside consultation, if you will. There's 4 caveats to Project ECHO. One is really a quality arm. It's really to reduce variation in care. We always comment on evidence-based best practices. It's a mixture of didactics and case-based learning. And if you want to offer what the difference between what a webinar is versus the ECHO model, it really is the cases. Real HIPAA compliant de-identified cases are always part of an ECHO session. Technology is clearly part of it. We are a virtual telementoring program, so we use technology, and definitely broadband is essential. And our barriers come when technology, as Maggie said, is not available for many of our rural communities and our patients who are marginalized. And then finally, we always measure outcomes. Next slide. So really, Project ECHO works best when specialists are able to teach primary care providers, whether it's PAs, nurse practitioners, psychologists, physicians in rural and even underserved community. We know that there are not enough specialists everywhere, and so it's a way to reach those primary care clinicians and train them. Knowledge is moving at a quick pace, and it's a way to reach clinicians who can then reach patients so that they do not have to travel. ECHO trains primary care clinicians, again, to receive these specialty care services, and one of them is pain, integrative pain services. Next slide. So the ECHO model, by doing this, builds capacity. The hub is at the left, the hub team. We train clinicians who will then give their knowledge by managing their patients with more evidence base and more tools. Next slide. This is an example of a Project ECHO in process. This actually happens to be not an ECHO pain program, but a hepatitis C program. This is a diverse team of specialists in the big square. There's a hepatologist, Dr. Aurora, there's a pharmacist clinician, there's a psychiatrist and a social worker, and then all the little squares are all the different outlying clinics that are calling in and presenting different cases to this 90-minute session. Next slide. So knowledge is democratized. We give all our didactics to all the other hubs around the world for free. We give all our didactics to our learners for free, and we share whatever we have during the actual session. Next slide. We know that ECHO works. The original data from the hepatitis C literature in the New England Journal of Medicine in 2011 compared what Dr. Aurora was doing at the University of New Mexico hepatitis C clinic. He had 146 patients. He had a pretty good cure rate, but not as good as a cure rate as those patients that he helped to treat by training primary care clinicians in rural and underserved community. The bottom line is that the clinicians who he trained via the ECHO network, those patients actually did better when it came to cure rates from hepatitis C. Next slide. What I can tell you is that many other conditions have also replicated the same study that Dr. Aurora has done, not only for hepatology in improvements in mortality and morbidity, but we've done this, and I'll show you in a few slides, with the Army and the Navy with reducing opiate and benzodiazepine doses. So we're seeing, we give ECHO sessions to diverse audiences, to FQHCs, specialists, community providers, and to the federal government. We're doing programs with the Indian Health Service, with the CDC, with the VA, and with many academic medical centers. Next slide. We have over 70 different conditions, primarily medical, but we've, over the past 5 years, we've expanded tremendously into quality initiatives, into public health initiatives, and into education. As you can see, they range from programs, from behavioral health programs, chronic pain and addiction, but also to high-risk pregnancy, LGBTQ health, palliative care, and prison peer education, to name just a few. Next slide. So how is Project ECHO telementoring different from traditional telemedicine? The bottom part of this slide, traditional telemedicine is extremely important, especially during our COVID pandemic era. We very much need to manage patients remotely if we cannot see them in person. So the one-to-one managing of a clinician to a patient via Zoom or another virtual network is perfectly fine, but it does not build capacity. The top part of the slide really shows that through the ECHO model, the expert hub team trains learners at the spoke site and then is able to exponentially reach many more patients. Next slide. This is our ECHO Pain and Opiate Management Clinic. We've got a wide-ranging group of hub team interdisciplinary specialists. We started in 2008. My back is to you. I'm in the pink sweater. Dr. George Commercy, kind of my partner in crime. He's an internist with a pain specialty. To my left is Dr. Lucy White Ferguson, a chiropractor. On the far on the wall is Dr. Ben Dates, who is an international expert in myofascial pain. Next to him is Don Aquilos, a psychologist. We also have around the table, closer to the screen, is an addiction psychiatrist. And we also in the room have a clinical pharmacist. Not seen, but also on our team at this time was a physical therapist. So we've got a diverse team. What we try to model a best practices comprehensive integrative clinic, even though we know that the clinics calling into us and the providers calling into us might not have these services, we still want to model a best practices program. Next slide. This was our curriculum. I chose a curriculum from the last couple of years. We have a weekly clinic that meets for 90 minutes. As you can see, we have kind of modules. The first module was opiates, overdoses, and education. If you go to the fourth module, you can see hands-on skills. The beauty of Project ECHO telementoring is because of our, because everyone is on video, we can show things extremely clearly. We can use an iPad and we can go extremely close up, so we can demonstrate the chiropractic exam, the myofascial exam, trigger point workshops, kinesiological taping methods. We can show the physical exam and the neurological exam. And I'll tell you in a minute, this doesn't necessarily make the clinician an expert, but it certainly gives them awareness that there's more to chronic pain management than writing a prescription for hydrocodone or oxycodone. Now they know that, but it gives them ideas that there are more tools in their toolbox. Next slide. We have a module on Native American health and wellness. We have a close partnership with the Indian Health Service. As you can see, we have modules every year on integrative pain care. What is best practices for, it should be integrative pain care, dietary supplements for migraine, acupuncture, and pathophysiology of taping. Emerging treatments, we talk about medical cannabis and herbal medications. Next slide. We bring in specialists, I also might mention, from around the country to speak. And that's the beauty of Echo Pain, is that we have a network of specialists from around the country. So for instance, we'll ask my colleague, Robert Banakdar, to come in and bring it to speak on nutrition and pain, or we'll bring a specialist from the Indian Health Service to talk about herbal medicine or trauma-informed care, things like that. So the education of primary care provides, it's a weekly program. It's a mixture of didactics and case-based learning. Clinicians receive CME at no cost to them. And this program also fulfills our New Mexico state requirement for pain CME. New Mexico had one of the first, if not the first, requirement in the country for mandated pain education. Next slide. Just to reiterate and to really focus on the skills that we're able to demonstrate, they include chiropractic care, physical therapy and other rehabilitation therapies, acupuncture. We have a very well-known acupuncturist in Albuquerque who has her own community acupuncture business, who gives a very good evidence-based lecture every year and demonstration in our session doing that. Myofascial pain techniques. We have, because our pain center is, our faculty on our hub team at Echo Pain are also the faculty at our UNM Pain Center. We're able to bring these techniques to our Echo Pain program more facilely. We have nutrition demonstrations, behavioral interventions, Native American and kinesiological taping methods. Next slide. And then I mentioned before the exams we're able to show. We also demonstrate talking. So we'll demonstrate a patient-centered interview. For instance, Dr. Commercy will demonstrate. I'll pretend to be a patient, or he'll pretend to be a patient, and we'll do a role playing together. Same thing. We'll do that role playing with a controlled substance agreement. We'll bring in a motivational interviewing specialist, and we'll talk about motivational interviewing techniques. So important in pain management. Next slide. Our programs, like I mentioned before, are embedded. We have most of the federal agencies are very aware of Project ECHO for pain, and we are currently doing very large projects with the Indian Health Service. We're currently doing a very large project with the CDC to train all Public Health Commission Corps officers in chronic pain and safe opiate prescribing, so that they can be ready to be deployed if a pain clinic or opiate clinic is closed because of a DEA action. And we're closing out a program with the CDC looking at integrative chronic pain management. Next slide. These are the areas where we've trained Army and Navy TeleECHO clinics in the United States, in Europe, and in Korea and Japan. Next slide. This is a study that we finished about 1.5 years ago and published in the Journal of General Internal Medicine. I have the references at the end of the PowerPoint, but we showed significant drops in new opiate prescriptions, in changes of dose of opiate, in co-prescribing of opiates, and in days of opiates and benzos with the Army and Navy clinicians who participated in ECHO pain, as compared to the Army and Navy clinicians who did not participate in ECHO pain. They had to participate at least 4 times, and the patients whose clinicians participated in ECHO pain had significantly lower doses of these prescriptions. We're looking now at other integrative markers. Next slide. This shows you that with our addiction clinic, this was published a couple of years ago. We've started we've done many trainings on data waiver training, and in New Mexico really leads the country in per capita clinicians trained in buprenorphine prescribing. Next slide. And just very briefly, I wanted to tell you about how our program, our collaboration with the Indian Health Service led to us not only teaching about integrative pain management over Project ECHO, but then our ECHO pain faculty, which is the same faculty as our University of New Mexico pain faculty, we then went on the road. Next slide. And this was pre-COVID when we were able to travel. We then went to the Portland area. We went to Navajo area, which is really in our backyard, to Phoenix and Tucson area, and to Oklahoma City area. And we've been to the Bemidji area twice to actually teach these clinicians in primarily very rural sites about pain skills, myofascial training, acupuncture, what is Project ECHO, and then finally we gave them medication-assisted day-long data waiver training. Next slide. We reported this in the Journal of Pain Medicine, in that before they participated in this training, they felt like they were lacking in assessment and screening and hands-on skills primarily, and then after, their scores significantly increased. Next slide. This table showed that the self-reported confidence increased in their ability to deliver neurological exam, myofascial exam, and musculoskeletal exam. Again, we deliver these hands-on skills directly to these clinicians. Next slide.
3-minute warning.
Thank you. And then finally, I'm getting near the end. This is good timing. This is the curriculum we're now using with the U.S. Public Health Service that I mentioned, where it's a 16-week module. And again, because we're working so closely with the CDC, we're a little bit bound with, I apologize for the noise. I can't do anything about it. We're a little bit bound with the information having to stick with the CDC guidelines, but we have a couple of modules, 12 and 13, on integrative pain management. And if you go to the next slide, all these weeks, we have cases that we've designed specifically to go over integrative pain. So we have about 20 commission core officers at each session. This illustrates best practices, non-pharmacologic chronic pain management, and we go over the case in depth, and then we have a very robust conversation with the clinician. Next slide. We talk about, at the end of the case, we talk about please consider physical therapy, pool therapy, trigger point injections, traditional healing, behavioral health, chiropractic medicine, and acupuncture. Next slide. These are just other programs that we do at ECHO. We do national opioid programs funded by HRSA. Next slide. And the VA has multiple scan echo programs. If you could just forward to the ECHO benefits and challenges, that would be great. Right here. This will be my last slide. There's many potential benefits and challenges, and the potential benefits are really the quality and safety, that we can teach quality and safety by evidence-based, always talking about evidence-based guidelines, evidence-based literature. We're always sending the clinicians these journal articles, reducing variation in care. We can rapidly disseminate information. We have over 100 articles worldwide on improving professional satisfaction and retention. It's extremely cost effective. We avoid testing and travel, prevent cost of untreated disease. And again, the hallmark really is it's such terrific access for rural and underserved clinicians so that they can take better care of their patients. The potential challenges really are clinician time, as you know, especially employed clinicians, leadership buy-in, so those two go really hand in hand, financial strategies, really how to pay for the clinician time, and then broadband infrastructure that Maggie Buckley so eloquently stated, especially in rural communities. The one thing I will say about the ECHO Act, and then you have you can refer to slides at the end of this PowerPoint, is that the ECHO Act did pass in 2016, and we're waiting for the next round to pass, but it will look for strategies aimed at sustaining ECHO in a real viable way. Thank you all.
Thank you so much, Joanna. That was really excellent and such important information for all of us right now during this time.